had a good meeting last week, as we began last Monday. And this afternoon, we're going to focus on a couple more big agencies, DMAS, the big agency with lots of things to do. Then we're going to have, of course, Cheryl Roberts and her crew here with the Department of Medical Assistance Services, and then Daniel Wolin from the Department of Social Services. Oh, that's right. We're live online. I apologize. So I'm supposed to speak to the microphone here. Apologize. With that, does any member have anything you'd like to bring up before we go any further? Okay. If not, we'll call on Cheryl then to come to the table and share with us all the good things that she and her crew are doing.
Hi, how are you? Good. Most of you know me for years, I guess. I'm Cheryl Roberts, and I'm the director for DMAS. And I'm going to do a couple of things today. I'm going to talk about where we are, okay, how 2022 looked like, 2023, and then do the governor's budget. Okay. Okay. If you go to, I'm going to push you all the way into the slide here. This gives you a sense of where we are. We are at 2.2 million members. I can wait. Okay. Children are still number one. That's going to be important as we start to talk about it. The biggest jump you should see now is adults. If you look at that, that's going to be important as we start to talk about the enrollment and the redetermination. That was our biggest and largest jump since 2020.
Madam Chair, Mr. Chair, is there anything, any one of these bars that hits the limited, the people that just came on since we've been in a state of a medical emergency?
We can get you that information in particular. It's about 500,000 people.
Okay, about 500,000 people.
Delivery system-wise, we have two delivery systems right now. We still have Medallion, which is about 1.6 million people, and then we have the Commonwealth Care, which is about, if you notice here, about 300,000 people. Commonwealth Care is the most complex, right? That's where you look at your long-term care, people with complexities, disabilities. Medallion is what you normally think of women and children and adults in terms of those programs. And right now, we're in the middle of combining those programs to make them one. So the combination of the two of them will give us one program that we're branding called Cardinal Care. And I'm making it, my comment is, this way. So by the time we get to the spring, probably by March, we will get the federal approval for that program, which is called Cardinal Care. So you'll have the little red bird now and the red color. That's why I'm wearing red, to get you into the cardinal. Mm-hmm. And it's my sorority color, as you know. So I'm getting into the cardinal. Huh? Yeah, I'm being consistent with the red, okay? I'm getting the red. And that's the first part. The first part, obviously, is to bring the programs together. That's some of the complaints we heard from providers, that they had two separate programs that they had to navigate. So this will bring that together. This is just to give you a sense of the money. We spend about $20 billion at this point. About 97% of that is Medicaid funds. We are very efficient. We only spend about 1.7% on admin money, but this is to give you a sense that we're growing, but growing efficiently. Yeah. This is something I do want to thank you for, so I wanted to stop and talk about our highlights. Last year was a good year for us. We did a lot of good things that were good for the Commonwealth and for our members, and a lot of them came from you. So I wanted to give you a chance to say that thank you to some of the things. One were the rate increases. Getting the rate increases made a difference to our populations, both maternity, dental, some for the community mental health, the personal care. We're hearing good stories. Like, for example, is when I went to Crossover, they talked about how they were able, because of the rate increases, to get more people care and get new cares. Good stories we're hearing from the rate increases, so I wanted to thank you for that. Second things that we're seeing is things we're doing is innovative. First time we're doing a nursing value-based purchasing program on nursing homes. That's well received. Even the nursing home people are liking it. This is good. Okay, okay. No, you got to take it what it is. And we're happy with that. We're seeing good things there. It's the beginning of innovation. So while we were quiet, we were actually doing some good things there. For maternity, we actually were the third state to start doula benefits, and we're actually having deliveries now. We actually have healthy babies coming out from the doula. So that's working well. I'm still trying to beat New Jersey in the number of births, but it's still doing very well. And then the last one I want to bring up is the partnership for Petersburg. That's the governor's initiative in Petersburg. We spent a lot of energy this year actually trying to make a difference there. Funny, people ask me why Petersburg. Petersburg's numbers are atrocious, to be honest. All of our health numbers are very bad. However, we did not pick it up, and I'm going to be honest, because we do regional work. And since we do regional work, it got lost in the Richmond region. If you look at it regionally, you say, oh, Richmond is doing okay. It's only when you pull it out that you actually can see how bad it was. Lessons learned. So we spent a lot of time with the health plans doing events. We did about 40 events there. We did some initiatives that were targeted. One of them I want to talk about, like, was maternity. We saw that 80% of the women were not getting prenatal care. So we did a targeted write-up and call campaign just there and switched it around. So now 80% are getting care instead of the 20. So we feel good about it. But what we're learning from Petersburg is how to replicate it. And one of the things we're going to be talking about when we think about things like the procurement is not to just think about regional issues, but start thinking about community issues, using the data to be able to drill down to do some community work. So Petersburg was good for Petersburg, but it's going to be good for the whole program. All right, for 2023, I'm making a joke. I say, what is 3 for 2023? Ready? All right. The first one is the unwinding, and it's probably the biggest project that we're going to be working on all year long, to be honest. As you all know, for 6.7% since March of 2020, we got extra 6.7% FMAP, which we're happy with. But also with that was the caveat that we would also maintain people and not turn them away or turn them out of Medicaid. That maintenance of effort meant that we had probably increased about 500,000 people over 2020. However, the state did benefit. Financially, it was a great benefit for us. The question is, how do you stop it? Okay, so here you have a big nationwide stoppage, right? Where before you actually said that everyone has to stay on, and then the issue is how do you begin to stop the process? So in December of 2022, the federal government finally said the end date is March of this year, coming up, March 31st. And that began a process that now we're going to have to redetermine all 2.2 million people in the next 12 months, about 166,000 people a month. Okay, huge undertaking. It's going to affect every piece of our programs and our businesses as we look at it. So what we're looking at is a positive. First, HHR, and I think you actually asked us to do that too, actually started a work group and a collaboration with my partner in crime, my partner in care, Dr. Avula, and we've been working together to actually create a super plan to how to tackle this, both what can we do as DMAS and what can they do with, and in terms of the locals. What we do expect is some up and downside, right? So it's definitely going to affect our members. We're going to talk about that. We're expecting about 14% of the members to transition out of Medicaid. We are hoping that the majority of them have jobs. We're hoping the majority of them then would then also go into the exchange. But we do know there'll be some transitions. We know that. And we also have some financial things that are going to occur. So I'm going to go with the first one. Let's talk about the members. We're going to start in March sending out letters to begin to start to tell people that you're going to have to get redetermined. That's important because that has not happened for 3 years. So there are people who don't even know what that means. So we're going to have a big education and outreach campaign. And the way it will work, and that's what this shows you, is that each month we'll be starting with a group of people, trying to get them redetermined, and then we hope by the end of May 24th to be over with. Right? So we hope that this will be successful. The good news is that it's a national program, that it's not unique to just Virginia, so that we'll have that kind of synergy.
Mr. Chairman?
Yes.
I guess a comment. You speak so clearly, and I so easily understand what you're saying, that I'm very hopeful that when you do this, you do it in language that people can understand and doesn't have any of the jargon that goes with this.
Well, we're really working on it.
Okay,
Okay, we're working on it. And so I'm going to show you the long list. So if you turn the page, you're going to get the long list of the things that we've been working on. The actions on the unwinding. Clearly, the first thing is our partners in DSS. So the way it works is, if you had to think about it, is people are going to have two ways they can go. They're either going to be able to go to Cover Virginia, where Cover Virginia is our contractor, and be able to do some of this either electronically or some of this by phone. Or, as you know, people are going to walk into a DSS office. We're not going to stop that. And that's going to be part of the challenge. So one of the things we did first is actually do some system things, so that what would happen is that we could do it automatically, so the person would have we don't have to be touched, and that will take care of 30% of the membership. So that's the good, right? So 30% from the top, we know already we can handle systemically. But then we have the two issues, right? People going into a DSS offices, knowing it has vacancies, that's no question, and then people coming to our contractor and trying to do that on a timely basis. So what we're doing is working on that. So I'm going to let Danny talk more about what he's doing on the locals. We're working, like I said, on the system changes. We're doing a lot of work with the contractors to try to get information, work with VEC, any information we can get to make it simpler. Trying to get our contractor in place, you'll hear more about that in a minute, to get that lined up so that contractor will be staffed up and ready to go by April 1st so that they'll be able to take the calls. Doing a big member outreach, answer your question. Everything that in different languages, trying to get to people. Working with stakeholders, already started that kind of work with ambassadors, and telling providers now we need them to be able to engage, particularly providers with the behavioral health side. Right? It's going to be one of those where you have to get people to trust. I've had that discussion. The MCOs are engaged already. We have them with address changes, and obviously they have a vested interest in making sure that that person gets redetermined, and so we're having them engaged. And then last but not least, we're working with the exchange. We're trying to do a transition so that that's an easy handoff. Okay, so I look at your face. Your face is reflecting mine, but it's going to be good. All right. So,
A lot of work for you all.
but I'm proud of the fact that we worked together to get to this. Okay, and a lot of states have not, and we're getting kudos to have the plan.
Question, and you may be going to do it, or Dr. Willa, but your contractors, you're having RFPs, they're already out, what's going on?
We have a contract. Cover Virginia already exists, and so this will be an add-on kind of a product.
Okay.
Okay.
Should not go into the open market for a contractor.
We don't have enough time. We have literally 54 days. Mm-hmm. 54 days. Let me tell you about the money. All right, good and bad. Okay. So good was, if actually the Medicaid Association actually lobbied CMS to say that you should not cut off the money straight because we're in the middle of doing all the redeterminations, right? So the good news is that the federal government decided a tiering program, which means that at least there'll be some funding, extra funding, until the end of the year. The downside is that where we thought we were going to get the 6.7% until July, they're stopping that, and they actually are now starting at 5%, which means that we're going to need $29 million to finish up the year. Okay. On a positive note.
I was unaware of that. So this current, well, the upcoming quarter, they're going to start nicking us then?
Yes. They decided to drop. Okay. Let me tell you the positive. This is a positive. Next fiscal year, which we did not expect to have any money, and we will. And so as a result of that, we'll get $130 million, so we'll net $100 million.
Okay.
So altogether, it works out, but it's not good right now.
Two of us are happy to hear you getting 130. Right? We'll pay you 30 if you'll give us 130 back. So.
That's what we're saying to you. Okay. But what we're telling you is that that's not what we thought was going to happen. So we know we have a need for $29 million. Okay? All right. I'm going to number 2, which is behavioral health. The governor's number 1 project is behavioral health. And obviously, you have behavioral health transformation. I won't go as much detail into this because obviously my counterpart was here last week, and I'm sure he went into detail of all the pillars, so I won't go into all of them. We're involved in several of them, obviously the capacity, the crises, the substance abuse, and the delivery system. And so that's the part that DMAS will have a big place. So, what we're looking for. On the downside, Virginia is 46th in behavioral health for kids. Remember I went back and I said we're number one for kids? That's a bad trajectory. That's not what we want to see. So I'm glad to have this opportunity to start to work on that more on a focused basis. And so this gives us that opportunity with this plan. You'll see that we're building on Bravo and Arts. Bravo is obviously with our community work, and Arts is our substance abuse program. We'll be building on that. We were working with Janet Kelly on Safe and Sound. Remember that, the displaced kids? One of the things we learned from that experience, positive, is that working together with the provider community and the plans and DSS was a good thing. On the other side is we realized that we had carved out RTCs from the managed care program, and that made a disconnect that caused some of the problems. In other words, then the plan didn't know the kid was in an RTC and didn't know when the kid came back. Honestly, disconnect. So one of the things we're going to see in our proposals is to put RTCs into managed care, but by doing it with a work group, because we realize there's funding issues, particularly locality funding issues that have to be discussed and resolved. Okay, so what we're going to see one of our requests. But the bigger picture was we would like a child that once they're in the managed care system, for the managed care to be committed to making sure that the child is fine all the way through, and that means having control of all the modalities. Okay? And then the last one is we need to increase access and accessibility. That's going to be high on our list, and so I'm glad for any type of increases in terms of rates. It's because, as you know, it's difficult not only just to say that they're in the network, but actually have the time to see you. And so we're trying to open that up. Okay? And the third one is the procurement. Okay. Let's talk about this in terms of leverage. We spend about $14 billion on managed care right now. Okay? The last time we procured was in 2017, and a lot of things have happened since 2017. We've learned a lot of things. And one of the best ways to leverage that and find out what other people are doing nationally, we've seen great things happen. Even the things like we talk about that we consider normal, like social determinants of health. All those type of things can be leveraged. And so this is an opportunity to be able to leverage that to see what's the best we can get. And so we're going to be working on that. So in October, my boss, Secretary Littell, he did an announcement that said that that was his intention, that we would move forward, and we have. We then, at that point in the fall, had some stakeholder meetings where we asked all the stakeholders to give us our points. Because the one thing we have realized is that we don't know everything. We think we do, but we really don't. And we needed to get all the stakeholders in. So we had stakeholders give us input, we had members give us input, CHIP PAC, and we left it open so that people still to this day. So we still haven't finished getting as much input as we want, but we are taking that into consideration. And then the third thing we did was get a consulting group. The reason is that we recognized that we wanted to get a professional who was going to do the professional scanning, look at other states, and help us write it so that it was objective. We want to make sure that we leverage the best we can. So the goal is to put the RFP out late spring, early summer this year, for implementation of July of 24. Okay. This is what we hope to get from it. The first one is to be really member focused. That is really our focus. Is what can we do with the money to do the best we can for members. And so you're going to see here that there's a lot of focus on holistic care, social determinants of health, investments in communities. Remember I talked about that before. What are you doing to actually make a difference? And then different than the current business we have, we're going to be making it very much more outcome focused. Before it was more service focused, this RFP will be more outcome focused. And then also to deal with some of the financial issues. One of the criticisms we've had is that the profits that we've seen have been a little high. And so the question is, can we be able to do something with that? So this is an opportunity. We're asking you for your permission to move forward, and we ask for some finances. So let's talk about why. Yeah. Go ahead.
Quick question there. You talked about the profits. How do the profits here in Virginia with these MCOs, how do they compare with what other states have been doing? And how do you see it as it relates to the impact that COVID-19 had of basically people changing how they approach seeking medical care? And in many instances, and particularly early in the stages, a lot of people didn't go even though they should have. So,
Two issues. We understand COVID played a big role, and that's fair. That's no question. But the way we tiered probably was too generous. And most states are not tiering as generous as we were.
Right.
We had like three, and I think it's 3, 5, and 10, Chris?
3 and 10, yes, ma'am.
Yes. And most states did not do that. Okay, so regardless of COVID, if we could do it again, our tiering will be different. So yes, you should get a profit. We want every plan to have a profit. And then there has to be some point that we're doing some sharing, and then some point that it comes completely to the state. But those numbers should not be as high. And most states are lower than that. That's what it is. So it's not not acknowledgement that plans should have a profit. It's the question is we should tier differently.
Okay, Senator Dees?
Yes, ma'am. I was wondering, you were talking about more outcome focused. Outcome for whom? For whom?
For the member.
Remember.
For the member. See, what happens is that, again, when we did the procurement in 2017, it was mostly focused on the long-term care, the concept of going into long-term care, managed care. And we did that work. I mean, that was the work we did. But now, if you notice, even if you look at other states, Ohio, New Mexico, you'll see that there's a big focus on outcomes. And we want to go in that direction.
Okay.
Okay. I had a general question, I mean, I think now or later, but maybe Dr. Will would also get into it. But in terms of data, the cost, computer systems, all of that, to manage all of this data, as we disenroll and review people, has there been any significant involvement from our chief data officer and his office in how you're managing your data? Of course, when we stood that up, my thought was we would eventually have a lot of help for handling our data in uniform ways, reducing the cost of computers and software and all of that. So have y'all had involvement with the chief data officer yet in any meaningful way, or is that yet to come?
Are you talking about the governor's chief data or us?
The governor's chief data, the office of chief of data.
They have not talked to us yet. What we have done in DMAS, ironically, is that we do have a chief data officer. That's why when you said that, I said,
Yeah. Well,
okay.
Seems like your chief data officer should be talking to the governor's chief data officer.
Well, we'll have to make sure that happens.
Yeah.
Lynette's here, so she'll make sure that happens soon. But yes, but we have, like for example is, and I'm going to talk about that, we have dashboards, and we're going to have an eligibility dashboard so that will show everyone how this is going. So that's already in the works. So as the unwinding goes forward, you'll be able to look at that monthly and see how it's going, positive and negative, and we'll keep that going. So that's since we started with dashboards. We also have a dashboard on behavioral health that's live, if you have not looked at it. That's really wonderful to see. Has all the information and all the data. It's kind of interesting. All right, so the ask, I just want to make sure why are we asking for money? But if people ask that question this is not procurement money per se, it's implementation money. That's really, so even though the word says procurement, it's because when you do this type of implementation, you need system work, clearly contacting members, that's what that is. Members need to do that. We have readiness review, which is why we want to make sure that every plan that we have is ready to go. And then also rate development. Obviously, the things we just talked about, Senator Deeds, we need to do the rates. And so that will be part of that. And now that I did that, you really didn't need the rest. But I'm going to go through it and talk about what we put in the governor's budget. Because a lot of this overlaps, obviously, now. Right. On the first side is things that are financial. The first is obviously we're asking to finance our utilization and inflation. That was in our forecast. Nothing has changed since then. The next one is obviously our estimate, again, for the fund. Nothing has changed really there. That's actually great. The next two are talking about famous and M-chip utilization. That's standard here. The last one on this page here is, again, I already talked about the $100 million. This is the what happens when you finish the public unwinding. We've already done that. Then we had some service and supports requests. The first one is for the DD waiver. As you remember, the governor wants to eliminate priority one, and we do too. So this is where the commitment comes. This is additional 500 slots. 430 of them are for the family and individuals, and then another 70 for community. So we hope that that will go through. I already explained to you why we needed some funding for the procurement and implementation for managed care. I also talked about a little bit.
Mr. Chairman,
Yes.
Yes,
could
Senator Howe.
could we go back to the 500 additional DD waiver slots?
Yes.
As you know, we have had a terrible time filling the slots that we authorize. It's
Yep.
been an ongoing problem, mostly because of the workforce needs, because of the low rate of compensation. Is there anything increasing the compensation in the governor's budget for the DD waiver providers?
Well, I'm going to turn to Tammy. Luckily, I brought experts with me, so I'm going to turn to Tammy. Tammy?
I don't think there's anything in there right now, but we haven't seen everything that's gonna come through, but right now I haven't seen anything, specifically for an increase on on all of the DD waiver rates.
Okay, so actually, this is, the reason I bring it up is I think it's, some parents would be deluded into thinking it makes a difference. And adding slots without providers does not make a difference. So I think it's something we're going to need to address.
Right.
Mr. Chair,
Yes, Senator Barker?
I have put on the table, I think it's 5 increases for categories that did not get increased last year.
Yep.
Should we have enough money to go beyond 500 slots, at what point do you think we would hit the number that would not be, hit a number where there would not be enough providers to be able to provide services?
I think that if we have to go above 500, we should have a meeting with both Dibbets and DMAS, and we can go through that. We've spent a lot of time over the last couple of weeks answering your first question, which is to make sure that we're figuring out what barriers there are so that we don't have what we had the first time. Because some of that was administrative, and we're trying to make sure that we don't do those things. But the other question is, then we can do a quick meeting with Dibbets and try to figure out what that number could be. Okay.
Okay.
All right. I've already explained the RTC inclusion of why, and with Safe and Sound, why we thought that that would be a good idea to have a work group to try to work through including RTCs into managed care. Telehealth for the DD waiver, that is a flexibility under the public health emergency, but what we're trying to do is make that permanent. We have a real commitment to telehealth. Okay. And then peer recovery is another one that we had some barriers. This is mostly administrative, again, so that would be easier for more people to become peers. Okay.
Senator Howe?
I'm having trouble reading the chart because I'm seeing dollar signs but no amounts.
Right. Because we don't need, it's just more administrative. It's just language. It's not necessarily.
Oh, okay. It's like, okay. Thank you.
It's language. Okay. The next one was Cover Virginia, which is the contract that we were talking about. We had a settlement with them, and this is the additional funds we need to finish that settlement. But we have signed off on the settlement so that we'll be able to move forward. We already talked to you about the redetermination. That $20 million is what we plan to give the contractor to actually do the work we need for redetermination. Again, we mentioned it's about 166,000 people a month. So we need someone to do the calls and do some of the paperwork, and that's what we have estimated. Yes?
Well, the 20 million is in addition to other monies we're talking about here that's coming from the federal government to underwrite this?
Chris?
Yes, that's correct. This is American Recovery Plan Act funds,
Okay.
separate from Medicaid.
Okay.
The next one is for third-party liability. For those who are attorneys, this is for liens. We do liens in estates. And we have a backlog, so our goal right now is to resolve that backlog. And so we're asking for staff so that we can actually start to work on the backlog and the processing time, because people actually contact us about that. The next one is about contract costs. What has happened is, as we have increased our membership, we did not come and ask, which we needed to, about per diems. For example, like dental, transportation, they have per diems as part of their contracts, and so as we increase the membership, we need additional costs to cover those per diems. And then we have the outpatient rehabilitation. What we're going to do is align that methodology the way we have it now to be more like Medicare, and so that alignment is more language, but we ask for your permission for that. And then the last one is, interestingly enough, we saw a decrease in our TDOs, and so this is a reflection of that decrease.
Mr. Chair, can I ask a question?
Senator Vogel?
Thank you. I hate to ask you to go back for a second, but I would love to ask you to clarify something. That going back to the issue of DD waivers, and this has been, I know, an issue for such a long time, and going back to the question Senator Howell and Senator Barker asked, when it comes to increasing the number of DD waiver slots, you mentioned something that I thought was super important, and that was, as we continue to increase those slots, you referenced, I know we've had a lot of challenges. Just as Senator Howell mentioned, we don't want to leave the misimpression that somehow this is an automatic solution. And you said that you recognize that one of the issues was administrative. And I so appreciated that you mentioned that, and you said that you were working on addressing that. Can you just speak to that a little bit more when you said that you guys were doing something? Explain that to me, because I know just as a constituent service matter, I've heard so much about that, and I so appreciate that you mentioned it. So if you could just touch on that for 1 second.
Okay, I'm going to start it, but I may have Tammy complete it. So Tammy's ready.
And I don't want you to take up too much time, but
No.
just a minute or two.
What happened was we started an administrative process at the same time that we had gotten the slots that took more time than we had thought it was going to take. It took a longer time for the local CSBs to do, and by a while. And so as a result of that, that was a delay we did not expect. Now, and I'm going to give credit to everyone, we have it all mapped out, where we know now everything that we need to do in terms of times and processes. Tammy has worked on this night and day, actually. And so we actually know, example, how soon we can send the waiver in, and how soon that's going to work, and how the CSBs will get it. And right now, we're trying to work on the waiting list, right, which is like, how do you prioritize waiting lists and doing options there. But what this has done on the positive side, it has made us very, very linked to divots. And so now we've decided that we're going to have a dashboard for that, so that we can be accountable, so that when we say that this is going to be done, that we'll be able to see where we are and be accountable for it. But I'll let Tammy also add.
You said everything, but we also have it, we do have it mapped out, and we do have the timeline, and we do have where all the slots were from 2021, 22, where they are now. And almost every slot has been assigned and services have been started. There are still some that are still waiting for services to get started, but overall, most all have been assigned and started. So I'm happy to share. We can send that over to you guys, but
Mike, we'll show it to you.
It does give a good explanation of where everything is at this point in time. And that whole process that Cheryl was talking about, we're not going to be doing that anytime soon again, so that won't hold up anything, going forward.
And we'll send that to you. Okay.
But Cheryl, since we step back to that, I mean, in terms of what Senator Howe and Senator Barker were talking about there, isn't it true that the essence of the problem, though, I mean, you can improve your efficiency in administering the program, but until we pump the rates up enough for the people actually getting paid that are actually doing the work in the field, they may have a heart for it, but they still have to support their families. So
Absolutely.
until we get to that point, we're not going to be able to get all these waivers taken care of in a timely manner. Isn't that a fair?
Workforce is always going to be an issue this
Right,
year. And
Right.
anything anyone could do to help workforce would be good.
sure.
It's true. Okay, I want to make sure where I am. All right, and this one is the an increase for salary increases, ironically. Salary increase for the Southeast Training and for Hiram Davis. That's some This is just for housekeeping, mostly for the housekeeping group. Then we're adding 20 graduate medical education residencies. And then last but not least, obviously, we're moving, and this should make you happy, we're moving the rates over to us from Divots. Chris and his team are prepared for that. Okay.
Quick question, Mr. Chair.
Senator Barker?
The psychiatric residencies, I mean, we have had difficulty filling some of these residency slots that have been, and actually, we have had a program that has been implemented, I think, for about the last 7 years, that where we've had 25 slots a year, and it's now building up a little bit on that. And then we just started on the separate ones for psychiatric, although we had some, particularly at Carilion, that were in place as psychiatric residency slots previously. I have some concern, and I think the first year that we did this for fiscal '23, we did not get enough applications to fill all the slots. And so and that is not a problem just for Virginia, that's a problem for the whole country. There are a lot of residency slots that are available for psychiatric services that don't get filled throughout the entire country. So do you have any ideas on how you might be able to implement them in ways to be able to attract people to Virginia? And we don't have a whole lot of psychiatrists in Virginia compared to some
No, we need
other
them
states.
desperately.
Yeah.
Let me get back to you. This one
Okay.
is new, and Chris, we can talk about this after. We'll talk about this internally.
All right.
All right, that one we'll have to work on. All right. And then we're asking for rate increases, of course. Okay, so this is perfect timing, right? We're asking you for personal care increases. And then one of this is, I call it OOPS. This is early intervention services. Last year, we gave it to the admin part of it, the case management, but not to the actual service. And we're asking that we give it to the services.
Yeah.
And believe it or not, I am done. I hope that I gave you the three things, which was, 1, 22 was good. We had a good year. I mean, even our APA audit was good. We had a good year. We got 3 projects we got to work on in 2023. One is the unwinding, and we hope that we showed you that we at least have a plan. Okay, a plan. Okay, that's what we hope. But I don't have to come back mid-year to explain what happened to the plan, but the plan. We're obviously very committed to the behavioral health transformation. You're going to see some work there. We'll be engaged there. And then, obviously, we're trying to work on the managed care procurement. We believe it's outcome-driven. And then we're going to ask you that you approve what we have for the governance introduced budget, because a lot of those things are tied in there. And so we're asking for that. And,
Okay.
I'm grateful. Thank you.
Other questions? Yes, Committee one. Senator Barker?
Yeah. One word caught me, and that was telehealth. Just in the last week, I've read 2 articles that talked about mental health services being done by out-of-state providers, and some of it was just mental health companies. In some cases, it was just an individual psychiatrist type of thing. And apparently it was done under some federal action during COVID that provided an opportunity
The
for them
flexibility.
to come in. But it also pointed out that some of the ones that were operating, basically, it's a one-size-fits-all. So it was not really tailored to the individuals that would have been served there, and it does raise some concerns about quality of care and those types of things. So
We saw a bill is going through for that, to make it permanent.
make it permanent.
Yes, we saw that. We made comments on it.
Okay. And do you know when the federal exemption would apply here?
Right now, the flexibility the unwinding was actually uncoupled from the actual public health emergency, but we're hearing that they're going to end the public health emergency sometime this year too. So
Right.
then at that point, we'll have to start to address some of these other flexibilities.
Okay, because we don't need, given all that this guy and a few others of us have been through on trying to deal with a lot of these challenges, we don't need to create opportunities for people just to come in and be able to build up large cash sums on people who are not getting anything tailored to them. It's just,
Except a hello.
yeah,
Yes,
it's-
yes. Mhm.
yeah.
I agree.
Okay. All right.
Thank you.
Well, comment, thank you for your
Thank you.
enthusiasm. Hope it's contagious in your staff. It actually got me cranked up a little bit here. Okay.
Thank you.
You bet. Here's
Good
another
afternoon.
enthusiastic
Good
person.
afternoon, co-chairs Howell and Hanger.
I don't know if you beat that.
I know. I'll try to keep the energy up, but I will also try to shorten it up because Cheryl took all of our time. So, just kidding. Cheryl, it's great. Medicaid is very important. My name's Danny Avula, Commissioner of the Department of Social Services. Great to be with you all. I'll spend a little bit of time just doing an overview of how we're set up in our budget, but you guys have frankly been doing this longer than I have, so we'll go quick there, and then we'll jump into the governor's budget. So. All right, so quick reminder, we are one of 10 states in the country that still do this state-supervised, locally administered model of social services. So the vast majority of services that actually touch our citizens happen through local departments that are managed through their local governments. And so, you'll see on the left there all of the different types of services that the local departments actually engage in. They do the eligibility for SNAP and TANF and child care subsidy and Medicaid. They provide the family services, foster care, adoption. And then we support the Community Action Network, so those 31 nonprofits of community action agencies. And then on the state side, child support enforcement, and then we do licensing of assisted living facilities. We administer the refugee program. We oversee the 211 program, and you can see the rest there. We because of the role that our local departments play in determining eligibility, we are responsible for a number of benefits that end up supporting local economies. The majority of that is Medicaid, but you'll see approximately $21 billion of benefits, largely federal money, that comes in and then goes and supports local economies. Our budget, you will see, is complicated, a lot of different funding sources, and thankfully, there's a relatively small sliver of that is general fund, but the biggest chunk is our federal funds. About a quarter of that comes from our child support enforcement activities and collecting those payments that come in. There's a local match. About 15.5% of the money that goes to locals comes from the localities, and then 18% general fund. You'll see this is FY22. There was a large percentage that we won't see in future years of those federal stimulus funds. And then how is that general fund portion spent? You can see the biggest chunk of that is really in local department operations, and that supports the family services and benefit program efforts that happen on the ground. All right, so let's get into the governor's proposed budget. So we have organized this into 4 main categories. The first reflects one of our major priorities as an agency, which is really our child welfare program, and in particular, increasing kinship care and reducing congregate care. The second area is in information technology, sort of the digital transformation work that we're doing as an agency. You all were incredibly helpful in kickstarting that this past year with funding for our child support enforcement platform and our child welfare platform. The third is addressing workforce challenges. As Cheryl talked about, as you probably heard from a lot of the agencies, that frontline workforce is really struggling. And so there's a bucket there that talks about how we're going to support our local DSS, and then the fourth category is a bunch of technical amendments, reallocations of money coming in. So let's start with kinship care. The first here is proposal to sustain and expand kinship navigator programs. So it has been a big goal of ours to increase the number of foster care kids who are paired with kin placements. So blood relatives or what we call fictive kin, coaches, faith community leaders, teachers, neighbors, that can be a home temporarily for a child. And what we've seen is just a growing body of evidence that kinship placements result in much better outcomes for kids. And so we've really tried to shift our practice to get kids placed in those kin placements. And Virginia has done well in the last couple of years. We went from about 6% in 2020 to about 12.5% kinship placements, but we're still far off the national average. The national average is about 33%. There are states like Oklahoma, Connecticut that are in excess of 55%. And so there's a lot that we can do to help encourage kinship placements, to help financially support those placements. And so one of those things is the Kinship Navigator Program. So we had a federal grant that helped support Navigator programs several years ago. We built up 6 of those programs around the state, and they serve as a resource and navigator for families who are taking care of a foster child, and really help support them as they go through that process. This funding would help sustain those 6 programs as they come off the federal grant, and would help us expand to 6 more. So we'll get to 12 Kinship Navigator programs around the state. Second thing there, because everything costs more, and particularly caring for kids costs more, this is a cost of living adjustment, and you'll see it's a total of $4.3 million, but that's shared between the general fund and the non-general fund there.
Mr. Chairman,
Senator Howe?
what is a foster family paid a month to take one foster child?
For one foster child, Carl?
Good afternoon, Madam Chair. So it depends on the age of the child. So we have a tiered rate structure that 0 to 4 gets one rate, 5 to 12 gets another rate, and then 13 and above gets another rate. It averages somewhere between a little bit over 500 a month to 700 and something a month for the base rate. And then there's a whole enhanced maintenance rate, which I won't get too technical with you this afternoon, but the average rate is somewhere, base rate is somewhere between about 530 a month, upwards about 760, depending on the age of the child.
That strikes me as very low with what it costs to raise a child.
You would be absolutely correct. So that that's part of, to refresh your memory, that's part of what this second budget amendment is designed, as you all have taken on this in the past, is as the state gives a raise, we are increasing that base rate every year following.
That was my bill.
Yes, ma'am, that's exactly what so.
But 5% also seems low. So, okay.
I would agree. Okay, next category, digital transformation. So the first item there is an adjustment on the child support system. So remember last year you all funded our child support enforcement platform. We've started the process. We're actually on the final stages of procuring a vendor for that. Our bids have come back about $10 million over what we expected them to. This is not a general fund ask. This is money that it just needs to be appropriated from retained child support collections. The second, yes, sir.
I just wanted to note there that the conversation I had with Cheryl there previously applies here in terms of, if it hasn't happened already, it seems that coordinating with the Office of Data for best management practices when we're spending these large amounts of money on technology for data and what have you, would be helpful, I believe.
It's a great point. We have definitely been engaged with the Chief Data Officer on specific projects. My understanding is that the primary effort that they're invested in is when data needs to be integrated across agencies, and so they built this data trust. We're working with them on workforce data and the workforce dashboards. We are very engaged with the Secretary of Administration and the CIO of VITA in really trying to manage the costs around this. But I certainly, if there's a role for the Chief Data Officer, happy to bring that office in as well. It's a great point.
Chair, could I?
Senator Dees?
I was a little uncomfortable with the phrase unspent child support money, is that money that's collected from non-custodial parents that's supposed to be paid to the kids?
No, retained collections. Basically, there's a percentage of the money that comes into the child support enforcement program that is for administration. And so that's the money is coming from those administrative dollars, not from the portion of money that would go out to families.
Mr. Chair, what percentage of that is of the collection is that?
I don't know the answer. Do you know, Gina?
We would have to get, we could get you that number. It basically occurs when you have a custodial parent who qualifies for TANF. So there's an offset between the TANF payment and then the non-custodial parent's portion. We get to keep a portion of that because the TANF will pick it up. But I can get what percentage of our child support
Okay.
population is.
Okay, thank you.
All right, we'll follow that up, Senator Deeds. Thank you. Okay, the next item here is technology to transfer local departments who are in a shared support arrangement. So 120 local departments. 40 of them are in what's this sort of hybrid model where their IT is actually managed by their locality. And they've chosen to do that. It gives them sort of more direct access because their local governments have robust IT shops. The problem is the majority of things that we use require consistency and security according to VITA standards, and local departments don't always meet those standards. So as we move from the mainframe to the cloud, as we add new softwares, we need to ensure that these 40 shared sites have the licenses they need, the security they need, the infrastructure they need. And so this represents licensure costs to upgrade those 40 shared sites. Again, you'll see that split between the general fund and non-general fund. The next item is a rollover for CWIS funding. So this is the Child Welfare Digital Platform. As probably it was explained to you all last year, anytime you all appropriate money for one of these efforts, that is the beginning of a process where we then go to the feds and say, we've got money, we'd like to start this process. And that approval process from the feds, 60 days at best, and then that starts our work with procurement and with the AG's office. And so the whole thing, beginning to end, takes a year or longer. And so this is a request to basically roll over those funds into next year. Any questions about that? All right. Next bucket, really supporting the workforce issues we're seeing in local departments. So the first one here is really around how do we support local workforce for Medicaid redetermination. There's $10 million there, and this is specifically to pay overtime funds to our local departments who will be carrying a big chunk of this work. As Cheryl described, about 30% of these redeterminations are going to happen through the automated system. Another chunk is going to happen through the vendor that DMAS is procuring, and then or has already procured, and then the rest of that falls to the local departments. Now, we do have concerns about the local department's ability to do this. And yes, sir.
On that, the 10 million is there was 20 million federal money in Cheryl's budget. Is this a piece of that 20 million or an additional 10 million?
No, this is an additional 10 million.
All right, so we got 30 million on the table.
Yeah.
Okay, yeah.
I guess I wanted to describe the challenge that our local departments are facing. This is the impact of the pandemic in terms of enrollment in some of these different supports. 39% increase in Medicaid, 37% increase in SNAP, 20% increase in TANF, and it's the local departments that are dealing with all that. They're doing all the eligibility around this, and so pair that increased demand with big vacancies. These are the average vacancy rates across the state, about 14 to 15% vacancy rates in benefit and eligibility staff specifically. And so we really just need to figure out how do we better invest, how do we support that local workforce.
Just a comment, I'm still pondering one of the things you said in the beginning, that we're one of only 10 states where the state really has involvement with the Department of Social Services. In other states, it's all local. And I'm wondering how some of our localities would have handled this sort of increase in work over the last 2.5 years.
It's actually the other way around, Senator Deed. So we in Virginia, the locals manage most of this workforce, but in most of the states, it's the state actually supports that infrastructure. Okay, so I want to talk a little bit about what we've been doing and what we're facing here with readiness for unwinding. So at the end of October, we launched our training efforts for our local eligibility workforce, and this is really important because, and I think Cheryl mentioned this, but over the last 3 years, we've seen a ton of churn in the local departments. Just people who have come in and out, and none of them over the last 3 years have done any redeterminations. So we have huge portions of our local department workforce who've never actually done this work. So investing in their training it's something we've been doing over the last couple of months. That is ramping up. We're going to be doing more in-person trainings as well. It's been really hard to figure out, how to pin down a date because the public health emergency is just getting pushed out and pushed out and pushed out. But now that we know that April 1st is it, we're full on investing in the training of those local eligibility workers. Communications, Cheryl talked about data, the dashboard that DMAS will stand up. I think, maybe the only other thing, the system, the automated part of this, we have done 3 major upgrades to the VA CMS system to help do the automated redetermination. We have a couple more that will be done before April 1st. And then one that has to actually, because of the language in the bill that was just the federal bill that was just passed, we have to go back and tweak one of those changes a little bit. But we've been working arm in arm with DMAS for the past year, preparing for this. All right. The next, any other questions on unwinding before we move on from that? Okay. The next item here really points to the CPS infrastructure, Child Protective Services. So the OSIG report from a few years ago identified that to really meet the demand in Virginia, we would have to add 863 local department workers and 173 supervisors. So big needs to kind of get up to par with CPS. And this budget gets us, one big step there. This would add 60 workers out in the field, 12 supervisors out in the field, 5 regional staff to help support that CPS work, sort of regional consultants, and then 13 workers to man the CPS hotline. So some of you may have heard from constituents that CPS hotlines have really long and frustrating wait times. This is both the hotline serves both CPS and APS calls, and sometimes in excess of 2 hours. So adding 13 workers would significantly increase capacity and reduce wait times for that hotline. The third item here is a small piece. We've had 5 part-time management evaluation reviewer positions for the SNAP program, and that just helps us monitor data and ensure that we're compliant with SNAP reporting. And so this is a request to turn those into full-time positions. They have been very helpful in getting us to get under the national average in terms of our SNAP error rate.
Mr. Chair.
Yes, Senator Byrd.
Question on the CPS situation, which is even in Fairfax County, it's been a problem for 40 years.
Mm-hmm.
Back when I had foster kids, and but is part of what you're seeing here going to address some of the issues that have been played in the media of kids sleeping on floors in DSS offices and things like that? Or is there a comprehensive plan to address some of those?
Well, there certainly is. And the Safe and Sound Task Force, which Cheryl mentioned, has really been the administration's effort with DSS and DMAS and so many other partners because there's a spectrum, right? That part of that is what's happening with local DSSs, but part of it is, getting enough foster families to be able to support kids with higher needs. Part of it is, finding residential facilities who are able to take these kids. So we are working across that spectrum. I do think one of the huge successes of the Safe and Sound Task Force has been, when you've got multiple agencies working on this together and you can pull different levers and pull money from different places, there's a sense of urgency to get those kids placed. And so we've seen huge successes. So I don't think it's as cut and dry an answer. Yes, it will help to have more CPS staff because they're a part of that spectrum. But we also need to address every other step of that continuum.
Okay, thank you.
Okay. And then I think we get finally to the technical amendment section. The first here, we got the general fund last year for raises for our local department staff. This is a request for the appropriation of the federal match on that. The second item will be to rebase the agency appropriations. The third item is to shift the funding of the child welfare forecast. And what you'll see here is that there's been a significant amount of money that actually has been shifted into federal spending. And so we're actually ratcheting the general fund request down for the child welfare program. Basically, Family First and Medicaid. There have been federal funding streams that have picked up costs around adoption, around some placements for kids, and so that means less general fund spend. Next item is to fund the TANF and VIEW child care. Yes, sir.
Get away from it. Was the clawback on the SNAP program anticipated, or is that something that's just been levied?
The last item here? Yeah, so basically what happened was last year, like every few months, the SNAP program was changing the amount that would go to individuals. There was a particular month where our vendor, we sort of sent the information early. The vendor loaded up the new amounts one day early, and that resulted in an overpayment. It should have happened the next month, but it ended up happening the previous month. And so we reported it immediately to the feds. We've been in negotiation with the feds about paying that money back. They've asked us to pay it back, but they're also open to negotiation. So I think it is very unlikely that we will be on the hook for that full 6.1. We won't know for probably a couple months what we can negotiate that down to.
Okay.
All right. And that SNAP was the final item under our technical amendments. So we could talk a little bit. I mean, I know you all are always interested in the TANF block grant as a way that funds a lot of different programs around the state. I think I just want to bring attention to the fact that we are projected for a deficit in this in FY25, right? So over the years, with the increasing standards for TANF, so some more money is going out in TANF, and the addition of new programs, we're heading to a place where that balance that we have will no longer be available. And so there will be a time over the next couple of years where we really need to look hard at those organizations that are receiving money through the TANF Discretionary Fund. You all have printouts of what those organizations are, and either now or at a future date, we can talk about how do we maneuver around who's spending the money well, who's not. There is a report that should be coming shortly on that looks more at performance metrics around these recipients. All right. Mm-hmm. I think that's all we have.
I started to make a joke about the TANF block grant. The people who get elected this fall will have to worry about that. We can still spend this year. We're good.
Okay, great.
Thank you very much.
My pleasure.
Further questions? Thank you both.
My pleasure.
Dr. Bullock. Excellent presentation. And that is our docket for today, right? I think we will finish now. We will be meeting again next Monday, and we'll have a couple more agencies, I think, to report to us at that time. And also, at that point, we may be looking at some bills, perhaps. I'm not sure it'll be too early for those, but what do you, Mike, you got it? Yeah, probably a few by then. Anything else that you need to share with us before? Okay, all right. If there's no further business, committee will rise. Thank you.